So now that we've had a chance to reflect on the past and to look forward to the future, it's time for us to introduce this year's View from the Frontlines report. Welcome, first of all, to those of us who are joining us by webinar. For those joining us by webinar, Greg sent out an email link this morning. It has a link to the presentation. It also has his contact information. So if you experience any technical problems during the webinar presentation, you can contact him with the information in his email. And for those in the room, yes, this is being recorded and shared by webinar, but it's audio and our Prezi presentation only, so don't worry. What happens in here is not being broadcast to the world, thankfully. Il y aura du temps pour questions au fin de la présentation. Je vous invite de poser des questions dans la langue de votre choix, mais nous répondrons en anglais juste pour les traductrices de langue gestuelle. So we've had comments in previous years that the presentation of OCHART data can be a bit dry. Apparently, some people don't enjoy sitting in a dark room right before lunch watching 2 hours worth of slides of graphs and data. I don't get it, but this year we did put a lot of thought into how to present the data in a more visually appealing and engaging way for those of us who are not data dorks. We did consult with a communications group called Just Because, who gave us some really helpful advice about data presentation, but in the end it was the brilliant minds at the Ontario HIV Treatment Network who helped us to develop this new presentation format using something called the Prezi. So many, many thanks again to Lisa Campbell and to Maria Hatzapatalis, who is Maria in the room? Yeah, there she is. So to those two lovely ladies for all their work in creating this presentation. So I'm going to start by providing a brief overview of the report, and then Anita and Joanne will present some report highlights. Both the report and our presentation focus on data that suggest changes or trends, and data that we're not sure how to interpret. And that data that we're not sure how to interpret is also something that we've tried to incorporate into today's breakout sessions in the afternoon. All the OCHART questions and data are available on the OCHART website. But by just focusing on changes and trends, we're hoping that we can make the report useful as a framework for us to identify and to respond to emerging needs and to help shape future work. Also, like last year, instead of analyzing and reporting every single OCHART question in the order that it appears when you complete your reporting, we've clustered the data around 4 key outcomes of our work. And this is a way for us to better link data about what we do to the bigger questions and the reasons why we do this work. It's also a way for us to move from describing OCHART data to really analyzing and interpreting it and thinking about what it means, which again is something that we're trying to do in the breakout sessions this afternoon. And again, if you want to find data from a specific OCHART question, you can use the appendix on page 126, which shows where each question appears in the report. So we're now on the purpose of OCHART reporting, which we'll just briefly recap. We just heard a lot of great comments and suggestions in the room about how you have used OCHART data, how you might use it in the future. Some of the other purposes of OCHART reporting, which again some of you already touched on, first is accountability. As funders, we're also accountable to our ministers, so we use OCHART reports to explain and understand how public funds are being used to support community-based programs. And as agencies, as we heard, you use OCHART data for board of directors and annual general meeting reports so that they can also understand the work that you're doing in your agencies. Second is for planning. We look for patterns in the data, especially over multiple years, that suggest emerging issues and emerging trends. And in that way, we can work together to plan the services that we'll need in the future as the epidemic changes. And Charles mentioned earlier, trends relating to aging, which we'll also see a bit later in the presentation, are a good example of that sort of planning work. And finally, obviously, evaluation and program improvement. OCHART can help support your agency evaluations. I know many of you have used OCHART data to evaluate the programs in your agency, and it also helps us as funders evaluate and improve community-based funding programs as a whole. So to help us think differently about how to use OCHART data to support all these different needs, and to look at the data in a different way than we had in the past, last year we created a synthesized logic model, and it's on page 4 of the preface of the report, so little lowercase I and V, and it's also up on the screen. So the AIDS Bureau and the Public Health Agency both have logic models that explain the relationship between the activities that we fund and the changes or the outcomes that we expect should result from those activities. And our logic models are also in the appendix of the report. So this synthesized logic model combines our two logic models together, and it shows what together we hope community-based funding of HIV services in Ontario will achieve. So again, the logic model is a way to connect outputs, or what we do, to outcomes, the reasons why we do what we do, the change that we want to see in our communities. And it's a framework for us to analyze and to interpret OCHART data. And just to note that these outcomes are taken from our existing logic models. They've always guided our work. This is really just a way of making it a bit more explicit. So to read the logic model, we start at the bottom with the 4 gray pillars. And these are outputs that are associated with 4 different types of work that occur in community programs. So 4 different types of activities that may be going on in your agency. Those are education and prevention, care and support, community and organizational capacity building, and knowledge sharing, coordination, and collaboration. And the bullet points in each of those gray pillars are the outputs that you report in OCHART. So outputs basically are the tangible goods or services, the things that you do, number of workshops that you provide, number of outreach services that you offer, things that are tangible and countable that are produced by your programs. And these tangible items or outputs are a means to an end. And that end is the desired change or outcome that we expect to see. So for this report, we linked each output or each OCHART question to the short-term outcome where there's the closest logical link. I mean, we know in practice that outputs contribute to more than one outcome. For example, we linked workshops and presentations as an output to the outcome of increased knowledge and awareness. And that's because knowledge change usually is one of the most direct, immediate, obvious results of workshops. But obviously, workshops also contribute to other outcomes, like increased access to services or increased organizational capacity. So above the outputs, we see 3 levels of outcomes, and these are organized by time and reach. The short-term outcomes, which are in blue, occur first, and this is where we can really see the clearest link and the clearest cause-effect relationship between outputs, between the work that you do in your agency, and the outcomes that we see in our communities. These outcomes are where, as community agencies, you really have the strongest influence, and it's where we can most directly attribute change directly to your work. And these are the outcomes that we've organized the report around. The other outcomes in red and green become more challenging to measure as we move up the logic model and as we move out in time. Intermediate and longer-term outcomes take more time to achieve, and they also really depend on the work of a lot of other programs and a lot of other sectors. So as community agencies and also as funders, we can all contribute to these outcomes, but they're influenced by a lot of environmental and structural factors that are beyond our control. So turning to the report itself, to the View from the Front Lines table of contents, parts 1, 2, and 3 are contextual information. It's epidemiological data, how we work, who we serve. Part 4, which this year is titled The Impact of Investment in Community-Based HIV Services, presents the data organized by each of those 4 short-term outcomes in our logic models. So today we're going to present some highlights from each report section. Increased knowledge and awareness. This is so cool. Increased access to services. Increased individual, organizational, and community capacity. And increased coordination and collaboration.
We have some sound effects.
We'll let you all provide those sound effects in your head, in your quiet voice. So I'm now going to turn it over to Anita to provide some information on the provincial context.
Just to note, if you have questions throughout the presentation, just make a note of them. We have a section at the end devoted to question and answers. So I'm just going to start off with briefly reviewing some epi data to show the provincial context that we're working in. The information for this section is found on part 1 of the View from the Frontlines, which is Trends in HIV Infection, and it starts on page 10. So the next few slides contain data that comes from the Ontario HIV Epidemiological Monitoring Unit at the University of Toronto. In 2011, the total number of new HIV diagnoses was down about 8% from 2010. It's important to remember that HIV diagnosis data shows the rate at which people are being diagnosed. These individuals are not necessarily newly infected. These numbers also don't include the estimated 20 to 30% of people who are HIV positive, but who have not been tested or diagnosed and don't know their HIV status. The decrease in new HIV diagnosis is encouraging, but despite the decrease, gay, bi, and other men who have sex with men continue to have high rates of new diagnosis. Within this group of men, many of the new diagnoses are in men over the age of 40. This figure, which is on page 10, shows the HIV diagnosis by gender and year. It shows data from 1985 to 2011. In 2011, the number of new diagnoses in men was 749. This can be seen if you look at the blue line. This is the lowest number since 2001. Also in 2011, there were 197 new cases of women, and this can be seen if you look at the green line, which is a similar figure to 2010, which was 192. This report also provides additional demographic data on who is being diagnosed, and that's on pages 11 to 14. So I'm just going to highlight a few things from that here. The populations most affected by HIV in Ontario remains the same. 50% of new diagnoses are in gay, bi, MSM, and about 1 in 5 are in people from African, Caribbean, and Black communities. Additional data in this report outlines that in some regions across Ontario experienced higher numbers of new diagnoses when comparing 2010 and 2011 data. So this next figure isn't part of the presentation, but it's on page 13, figure 4. So that's in the report if you want to follow along the next few stats that I'm going to provide. Central East had the largest increase in the number of new diagnoses, from 88 in 2010 to 107 in 2011. Toronto and Northern also experienced a slight increase in the number of new diagnoses, from 538 in 2010 to 552 in 2011. And in Toronto, the number, 538 in 2010 up to 552 in Toronto. And the HIV diagnosis went from 40 in 2010 to 44 in 2011 in the northern region. At the same time, Ottawa and Eastern and the southwestern regions experienced the biggest decreases in numbers. Ottawa and Eastern had a decrease from 192 in 2010 to 117 in 2011. And the southwest region, the new diagnosis decreased from 72 in 2010 to 47 in 2011. So moving along, we're going to talk a little bit about the community response to HIV. The following slides share some information about who our community agencies are serving. Based on the information that you provide in OCHART, it is clear that clients are experiencing multiple, complex health and social challenges in addition to HIV. And these challenges are related to the social determinants of health. Figure 17, which is found on page 31, it lists the top 10 challenges experienced by clients as provided by your estimates in OCHART. As this figure shows, the challenges have not really changed significantly over the past few years. The orange bars show the proportion of clients that face a specific challenge in 2011 and 12. And then the challenges are listed down the y-axis. After more than 2 decades, stigma and discrimination continues to be one of the most prominent challenges in our communities. Programs are now seeing a larger proportion of their clients facing issues of poverty, unemployment, food insecurity, mental health, and unstable housing. Over the breakout sessions, we'll also be interested in hearing about some of the strategies that agencies and programs are implementing to support the growing number of clients with these challenges. The next few slides take a closer look at who agencies are serving and the relationship between the clients and the populations being newly diagnosed. When we take a look at who agencies are serving, we notice that there's a range of estimates from different types of agencies and discrepancies between who is accessing services and the populations who are becoming newly diagnosed across Ontario. In particular, gay, bi, and other men who have sex with men account for over 50% of all new diagnoses and more than 60% of people living with HIV. However, they only represent an estimated 8 to 44% of clients at agencies. The exact figure depends on the type of agency and whether it's education, outreach, or support services that is provided. When we look at why this may be the case, there are a number of options to consider. So this slide can be found on page 29, and it's figure number 15. This figure shows the estimates of the proportion of clients that access services. On this graph, they're further broken down into the type of agencies, so whether it's ASO, community health center, non-ASO, or other health center. The bars in the graph represent the population, so the orange portions represent gay, bi, MSM. So if you take a look at the third portion in the graph, so that's the rightmost portion, and if you take a look at the gay, bi, MSM population, approximately 44% of the clients within ASOs are accessing support services. And CHCs provide support largely to heterosexual men and women, given their mandates to work with specific populations such as the African, Caribbean, and Black populations, as well as people who inject drugs. And the CHCs account for approximately 5%. And then the last column refers to non-ASOs and other healthcare HIV programs. And they estimate providing support to gay, bi, and other men who have sex with men and heterosexual men and women in equal proportions. So when we were trying to interpret this graph in particular, we also had some unclarities about how and why people are accessing certain types of services. So later this afternoon, this is one of the charts that you'll see in the breakout sessions, and we invite you to have a discussion about that, and we look forward to your interpretation as well about this chart. If we continue to look at the client demographics a little more closely, data from the ACAP logic models and the OCHART narratives indicate that programs are seeing many more newcomers to Canada, and they're working with staff to provide more culturally competent services to all clients. This poster that you see is an example of the provincial supports available to agencies to help them ensure that they are providing the culturally competent services. The Keep It Alive campaign materials were developed by ACHO, the African Caribbean Council on HIV/AIDS in Ontario, for use by the strategy workers across Ontario. Other agencies use the campaign materials to foster awareness and dialogue in their communities on issues related to prevention. A special thanks to ACHO for allowing us to share the poster today. The narrative data reports that clients who are newcomers also experience many of the health and social challenges identified previously. Newcomer PHAs continue to face complex barriers in accessing basic health, settlement, and support services. Figure number 16, which is on page 30, further looks at the reported estimates of client ethno-racial groups. The rightmost bar represents the 2011-12 H2 data. It shows that there is a continuing decrease in the proportion of white Western European clients, and this can be seen if you look at the orange and the purpley blue bars, and there's increases in clients who are Aboriginal and African, which can be seen if you look at the red and green bars. Based on what we know of the epidemic, the cultural mix seems to appropriately reflect it. So the next few slides will look at the client substance use across Ontario. According to the funded programs, 43% of clients use some type of substance. However, the rates vary. The highest estimates of substance use are seen in the northern region with 62%. Ottawa and Eastern region see rates of 56%, and the Southwest region with 45%. Figure 18 on page 32 shows the drug use pattern across the province for people living with or at risk of HIV. The colored bars represent the substances. As you can see when you look at the graph, opiates, which are shown by the dark blue bars, are the most commonly used substance across all regions except Toronto, where crack is the first. And crack can be seen by the beigey shell color, or actually it looks gray on the screen. Crack is the second most commonly used substance across the province, where again, Toronto is the exception, where opiates are the second most used drug. There's a slight variation across the regions for the third most common. For most regions, it's alcohol, which can be seen by the red bars. In Ottawa and Eastern regions, cocaine use is the third most common, and in Central West, alcohol and marijuana have similar patterns of use. And in Southwest, alcohol has a pattern similar to meth and heroin. The patterns seen here are also linked to the availability of drugs across the province. So we may also see some effect on the discontinuation of OxyContin in the future reports as well. It's important to acknowledge the context within which agencies are providing the services. Across Ontario in 2011 and 12, agencies reported a decrease of $1 million in funding due to fundraised dollars and funding cuts from municipalities. Yet, despite these decreases, we know that agencies continue to provide much-needed services to ultimately improve the quality of life for people living with, affected, or at risk of HIV. We're now going to shift their focus to the short-term outcomes of the work that you do. So this next few sections are linked to the logic model that Suzanne described at the beginning. The first set of slides looks at activities that lead to an increased knowledge and awareness in our communities. One of the key areas of focus for many of our community-based programs is to provide education for people living with at risk for HIV in order to raise awareness of the factors that put people at risk. In addition to providing workshops directly to community members, agencies are working within a broader community development approach to educate other service providers. In this context, they help create changes that will lead to healthier and more supportive environments for people living with at risk to access services. Page 36 contains figure 19, which shows the presentations and participation. So the number of presentations can be seen by the blue bars and the participants, the red line. In 2011 and 12, agencies delivered 5,535 presentations, which was up from 5,206 in 2010-11. However, it's interesting to note that these presentations reached fewer participants. So the number of participants were 141,000, which is down from 196,000 in 2010-11. Our thoughts on this is that the decrease could be as a result of fewer presentations delivered in schools. We hope that this indicates that there's a trend towards ASOs having more time to work with the LGBT youth and help create spaces for those youth in their schools. This next figure, figure 20, shows similar data, but it's specific to the ACAP data. ACAP funded 1 out of every 4 education presentations, which is approximately 1,300 presentations. And that again can be seen by the blue bars, and reached approximately a quarter of the participants across Ontario, or 34,000 individuals. Figure 22 on page 40 highlights the locations that agencies are delivering their presentations to. On average, overall, ASOs, which are represented by the blue bars, provide more presentations than any other type of agency. For ASOs, the majority of their presentations are delivered to health and social service agencies, schools, community groups, correctional facilities, and faith organizations. The locations here are also consistent with programs funded by ACAP. For programs within other healthcare organizations, which can be seen by the green bars, are more likely to deliver presentations to service providers, healthcare institutions, and workplaces. These differences in locations are in line with the differing program mandates. When we reviewed the narrative data, we saw a trend towards an increase in the number of presentations on HIV and aging, which makes sense in a context of an aging population of people living with HIV. In addition, agencies highlighted that they were receiving more requests for HIV 101 with long-term care facilities as more HIV-positive individuals are beginning to enter these programs. The next slide looks at evaluation capacity. According to the data reported, agencies are also building their capacity to evaluate their education work, which is consistent with their reporting requirements. 80% report measuring changes in knowledge, and 60% also measure intent to change behavior. Figure 23, which can be found on page 42, highlights how this evaluation capacity has been steadily increasing over the past few years. The blue bars represent the knowledge tools, the red bars the behavior tools, and the green bars both sets of tools. So overall, that's a snapshot of the education programs in Ontario. As you know, we've made some significant changes to the education section of OCHART. These changes were effective the last reporting cycle, which was October 2012, and we will be able to analyze and report the data from the new questions in the next View from the Front Lines, and hopefully that'll give a more fuller, complete picture of the education work that you do on the front line. I'm now going to pass it over to the lovely Joanne.
Thanks, Anita. I'm hoping this is resonating with you as we go through this data. And some of you I know may be sitting there thinking, oh, that's not what I see, and that's okay too. Or that's not what I heard as being the most, the highest drug of choice in my community. And, so this data, just to remind you, is a reflection on what you report to us, and we're giving you back an analysis of that information, right? So there may be other data sets that tell us other things as well, just to sort of contextualize it for everybody. The other thing I want to quickly point out before I get into the slides that I'm looking at, in the front, what's that called? In the table of contents, there is, it says executive summary, page 3. And then when you turn over to see executive summary, it actually says key messages. They're one and the same. The key messages are the executive summary, so you're not missing any information from your report. So it's very, so every year when we put together the View from the Front Lines, as I just said, this is always a report on the activities that you've told us you do. That's what goes in the View from the Front Lines. And this year we added two, maybe three different figures in there from another data source. And I felt we felt it was important to include this information in the View from the Front Lines this year because it really speaks to the success and the impact of your work on a larger scale, and we think it's important information for you to have. I'm not going to speak to it in great detail, and the document is available from the Ontario HIV Treatment Network, but just to give you a sort of a quick snapshot of the findings from an external OHTN study. We used the OCHART data, and which was focused on prevention. So this is a slide from figure 31 on page 52, and it shows the impact of community-based prevention programs. And what we know is that community-based prevention programs, the investment in those programs contributed to 12,087. God, it's a hard word to get out. So if you take a look at the red line, according to this analysis, between 2001 and 2009, your prevention efforts contributed to averting 12,087 cases of HIV, which in turn helped save the healthcare system approximately $3.4 billion in direct medical costs. So that's quite a thing to be able to say, and all of this in spite of Ryan Peck. We think it's all, we at the AIDS Bureau, David Holgrave is the researcher, right, who did some amazing work in the U.S., and he came to speak at an OHTN conference a few years ago and was able to articulate their response to HIV within this sort of framework. And we've been very interested to see some of that happening in Ontario. So this paper that was requested and the work between the Ontario AIDS Network and the Ontario HIV Treatment Network is very valuable information for us all. So having said that little piece, I'm going to move us on to talk specifically about the increased knowledge and awareness short-term outcome. So again, that's turning to your outreach activities specifically. So we feel that outreach is a key prevention activity in our sector. Evidence shows that when individuals receive education, support, and safer sex materials in locations where they're making decisions related to risk, they are likely to take steps to reduce their risk at that time. Therefore, for the purposes of OCHART, we define outreach as going to places where community members socialize, gather, or casually walk in. Nice little graphic there depicting that. When we reviewed the narrative for outreach to people living with and at risk for HIV, programs reported trends for more outreach to sex workers, more requests for outreach to women, trans, and LGBTQ youth, First Nation communities and detention centers, and men from African, Caribbean, and Black communities. The increased demand for outreach to sex workers may be due in part to last year's Supreme Court of Canada ruling with regards to sex work. That's what was noted by a couple of people that reported this. The next figure focuses on outreach to individuals living with and at risk for HIV. So I'm going to be talking about figure 24 from page 46 of the report. And this lists the top 7 outreach locations across Ontario. The most common outreach locations continue to be in bars and bathhouses. In addition, the number of agencies reporting online outreach is increasing, with 7 agencies that include 3 in Toronto, 1 each in Southwest, Ottawa, and Eastern Region, and Central East, as well as one provincial agency making up about 75% of the online outreach that was reported. This trend seems to indicate that online outreach is not replacing the more traditional outreach approaches across the province. It's unclear if agencies utilizing online outreach have developed more effective strategies to implement this work or better tools for tracking this work. In terms of outreach, we recognize that brief outreach, for example, during a community event, and significant outreach that requires a longer interaction, while both important, have different impacts. As many of you know, we've changed the questions for outreach in OCHART to sort of more accurately reflect that scope of the work, and you'll see a change in this data for next year. The next slide, with figure 34 from page 56, looks at the practical assistance provided to people who use substances. So here we see a listing of the average number of practical assistance services provided to people who use substances. Programs reported that more people who use substances are accessing services such as practical support, housing, food bank, transportation, tickets, while education and referrals to harm reduction and addiction services, social services, and medical services have remained fairly constant. These trends are promising, and yet we are unclear as to how to interpret them. Have programs been in existence long enough to have built more trusting relationships with clients who are now more willing to come into the fixed site and access services? Are agencies providing fewer outreach services due to internal capacity issues or external community issues such as police and enforcement issues? Sometimes we read about it, we see the trend, but we don't always know the full complexity of what's behind it. So I'm going to move on to the next slide. So figure 35 from page 57 highlights where outreach to people who use substances takes place across the province. For 2011-12, we see a marked increase in mobile outreach activities and outreach through drop-in centers to people who use substances. This seems to indicate that these are the most effective ways to reach this population. However, we don't know whether these activities are reaching more people or if they're reaching fewer people but more often. In order to better understand this trend, we need more specific data on outreach contacts. The marked decrease that you see on the slide in outreach to jails and prisons or correctional facilities is due to a shift in outreach activities of a few agencies only. It's unclear whether this shift was caused by a change in service delivery or a change in the way the data is tracked and recorded. So I'm not sure I would read a whole lot into that at this point until we understood it more fully. Figure 33 from page 55 compares the number of contacts made during outreach with the number of contacts made while providing services from a fixed location, that being in the main office or the office. Here we see a similar trend to that of practical assistance services provided. The number of outreach contacts dropped by 16,800, and the number of in-service contacts increased by 19,257. The report provides additional data about the number of individual clients who accessed outreach services. There was an 8% increase in the number of outreach clients who used substances. Among those who used outreach services, approximately 60% were male, 39% female, and 1% trans. Again, while we are unclear as to how to interpret these trends and what it means for service delivery and reaching people who use substances. Consistent with the trend of increasing outreach clients and in-service contacts, programs reported an overall increase in the number of prevention and harm reduction resources they distributed. I'm not sure why this particular graphic. I'm just going to go with it. I don't know, Charles. The number of condoms distributed increased by 26% in 2011-12. This increase was in the context of regular outreach for harm reduction programs and not specific awareness campaigns. In addition, some programs reported complaints about the brands of condoms distributed, and that some programs were getting requests from specific brands from clients. So seeing some of that, or hearing some of that familiar tension between what the health units are able to purchase or do purchase and distribute, and what people in the community are requesting. So this is looking at safer injection equipment. So there was also an increase in the amount of safer injection equipment distributed, as shown by figure 37 on page 59 in the report, despite the fact that 3 fewer programs were involved in this work. So even though, there were 3 fewer programs reporting on doing this work, we still saw a significant increase. Increases were seen across all equipment types, whether that be clean needles, filters, swabs, water, cookers, tourniquets, etc., with the one exception being sharps containers. The decline in the distribution of sharps containers may be more related to a supply issue rather than demand on the part of clients. We weren't sure what that was about. Yeah, we're moving on to safer inhalation. So figure 38 from page 60 also shows an increase in the distribution of safer inhalation equipment, including glass pipes, stems, screens, and alcohol swabs. This is to be expected as the number of programs that are able to distribute this equipment has increased. Across the province, programs reported more demand for safer inhalation kits, methadone treatment, practical assistance items such as winter clothing, basic needs supplies and food, as well as mental health services, which is what we would expect, really. So now I'm going to shift us to speak about activities that support the short-term outcome of increasing access to services. For each half-year reporting period, so just a reminder to people, there are 2 half-year periods, and we break some of the data down into those periods. 65 of the 88 funded programs provided support services to approximately 14,000 people living with or at risk for HIV. A small number of these individuals may have received services at more than one agency and were counted more than once. And you'd see that mostly, in the City of Toronto or maybe City of Ottawa. In this pie chart, slide 66, we made it specifically for the slide, In this pie chart, you see that approximately 70% of the individuals accessing support services were people living with HIV, 14% were people affected by HIV, such as partners, family, and friends, and 11% were people at risk for HIV. When we look at the gender of clients accessing support services, we see a slight increase in the number of females and trans people and a slight decrease in the number of males. The number of females accessing support services, has been steadily increasing in the past 3 years, despite decreases in the number of new diagnoses in women. Women account for a much higher proportion of new clients accessing services than their proportion of new diagnoses. This trend could be due to a number of factors. It may indicate that women make more consistent use of support services, that they have fewer resources and social supports available to them from other channels, that many women may be newcomers to Canada and have more complex support needs. It's a similar pattern that we see in other areas of healthcare where women are more likely to use services than men. Good. So if you look at the figure 41 on page 64, this shows the number of clients that access support services by gender in Ontario. The blue line represents males. I can't read that number at the moment. take off the glasses, 8,848. The green females, 4,799. And the red shows the number of trans people accessing support services, 212. Age catches up with me. The figure 56 on page 75 provides a regional breakdown of this data, the number of clients by gender. Again, the blue representing males, the green females, and the red shows the number of trans people accessing services in each of those regions. So to read that, you'd look for your region, and then you can see the numbers on the bar within your region. Figure 57, also on page 75, provides a breakdown of the number of trans clients accessing support services by population type, whether that be PHAs, people living with HIV, affected, at risk, or other. It shows that over the past 5 years, there's been a steady increase in the number of trans people accessing services, particularly trans people living with or at risk for HIV. Did everyone else hear that?
No.
To make sure it wasn't in my head. You never know. So this information poses a number of questions. Are trans people experiencing more marginalization, thus making them more vulnerable to HIV? How are services being revised to include trans clients or to become more appropriate for trans clients? And what are some of the successful strategies used to better support trans clients? What's working well, and how can we share that knowledge across the province? Always with these, information raises questions for me. Next, we're looking at the number of new clients. So we do ask that question in OCHART, sort of what is specifically the number of new clients. When we compare the number of new clients accessing support services with the number of new diagnoses in Ontario, new support clients exceed the new diagnoses. We believe this reflects the episodic nature of clients accessing community-based supports and services when and as they need them throughout the course of their lifetime of living with HIV. It may also be that some clients do not access community services as soon as they're diagnosed, or a multitude of other reasons. Figure 42 from page 65 shows what we just talked about with the number of new clients by client type for both reporting periods. The blue represents the first half-year reporting period, and the orange represents the second half-year. So the first half is April to September, and the second is October to March. You can see that the majority of new clients are people living with HIV, as we would expect given the mandate of our agencies, followed by people at risk for HIV and those affected. Sorry. So this slide is going to be talking about the age of those new clients. So we differentiate in OCHART between the new clients versus your existing client base. But I'm looking at this reading new age question. What new age text do we have? Oh my God. So in 2011-12, we asked you to report the age of new clients for the first time. When we analyzed this initial set of data, we found that a large proportion of new clients are over the age of 40. This is in line with the pattern we spoke about earlier, with a large number of new diagnoses being in people over the age of 40. Figure 47 on page 68 shows the age breakdown of clients accessing support services by region. When we further analyzed this regional data, we found that almost half of all clients in all regions across the province are over the age of 40. This raises some interesting questions for us, and we invite you to explore this issue in the afternoon breakout session. What are the implications? I'm not sure when 40 became the demarker for aging, but when I turned 40? Okay. What are the implications of this aging trend for our programs and services? How does this impact the support services we provide? How do we need to change our education and outreach activities to better reach these populations? How do we look at our community development work with this in mind as well? These are some of the questions and some of the discussions we hope you have later this afternoon. When we take a closer look at the types of support services that clients are accessing, we see that they use primarily practical assistance, case management, health promotion and treatment information, as well as referrals and counseling provided by staff at agencies. Figure 58 on page 76 lists the top 10 support services that clients accessed across Ontario for the past 4 reporting periods, with very little change over the past 4 years. Agencies report seeing an increased demand for food assistance, indicating that many clients face challenges with food insecurity as well as demands for practical assistance related to housing, transportation, and financial assistance. Agencies continue to respond to more clients with more complex care issues related to mental health, aging, and other comorbidities. As well, there is an increased demand for support with settlement issues and legal information on the criminalization of non-disclosure. Some of these shifts in demand are being met with increased referrals, counseling, and information support. Agencies also spoke about building new partnerships in the community. I think we heard that earlier today. Strengthening collaborations with other agencies, using technology to fill service gaps, and revising services to meet changes in client needs. This increased demand is clearly shown when we look at the financial assistance programs provided to clients. And if you're looking for the exact number of this, it's actually in the key findings section. It isn't in the data set. I went looking for it and couldn't find it, so that's how I knew. So the information is actually there in the report. It's in the key findings section, otherwise known as the executive summary. Agencies reported providing a total of $758,680 to clients, mostly for food and transportation. This is an approximate 16% increase over what was reported last year. Doesn't necessarily mean more went out because did we make that a mandatory question? I can't remember. Any OCHART people remember?
Yes.
It is mandatory now. Okay, so it is an actual 16% increase. That's good. And then transportation is primarily used to support clients with getting to and from their health appointments. This can be an extreme challenge in some regions, particularly rural and more remote areas where services are limited and spread out across vast distances. This is another example of where we've heard you and listened to what you wanted to, the information you wanted us to report on or collect. In past KTE days, we heard that one of the pieces of data that was consistently missing from OCHART were client deaths. Many of you felt it was important to report on this information. The number of client deaths were documented for the first time last year. In 2011 and 12, a total of 145 deaths were reported by funded programs. However, it's important for you to know that clients may access services at more than one agency, especially in areas such as Toronto and Ottawa. And since our numbers reflect agency results, the actual number of deaths may be slightly less. As well, keep in mind that this number reflects agency reporting across the province and may not align with official coroner data. So you might report that there was a client death and it would never be documented as an AIDS-related death, which is, it's about people who are accessing your services. So figure 53 on page 72 displays the number of deaths across each region and reminds us that HIV continues to be a life-limiting illness. Compared to the number of people served in each region, the proportionate number of deaths were particularly high in northern, southwest, and Ontario eastern regions. So if you look at page 73, figure 54, In the northern region, they reported that almost 10% of their PHA clients had died. In Southwest, it was about 5%, and in Central East, this was closer to 4% of clients. Regardless of the factors leading to these high death rates, these losses greatly impact everyone at the agencies, other clients and volunteers. And this may point to the need for advanced care planning and continued bereavement supports. On that note, we're going to shift our focus now to look at the short-term outcome of increased capacity, coordination, and collaboration. So as part of their ongoing commitment to MIPA and JIPA, agencies continue to engage people living with and at risk for HIV in their organizations. Across their work, they strive to develop more meaningful opportunities for people living with HIV and at-risk clients to participate in the agency and its activities. When we look at the data reported for employing members of their target population, approximately 75% of all funded program types, so whether that's an ASO, what we categorize as an ASO or AIDS service organization, a non-ASO, which might be a youth service provider, or a community health center, indicated that they had achieved this rate of 75%. We look at that more closely on figure 65 on page 86, which shows that almost 90% also reported having members of their target population involved in governance. For AIDS service organizations alone, so when we just looked at the AIDS ASOs, this was almost 100%, as we would expect. However, it is less clear to us who is represented in these target population numbers. This can, traditionally within the AIDS service organization sector, we mean people living with HIV, but certainly in other programs and more broadly, that could mean people using substances or LGBT youth or other peers, other peer groups. Are there some strategies that work better for meaningfully engaging members of target populations? What are they and how can they be shared? How can agencies learn that from one another? We invite you to discuss this issue as well more closely during the afternoon's breakout session. We couldn't at all leave this day without recognizing and acknowledging the important role that volunteers play in our sector, in our agencies, and the work that we carry out. Programs report that they continue to provide opportunities for people living with HIV and others in their community to volunteer. Some also reported an increased demand for volunteer opportunities from students, people doing community service, and foreign-trained professionals looking to gain Canadian experience. Across Ontario, volunteers contributed more than $5 million worth of time and skills, which I think we should. For your information, this calculation can be found in Appendix E in the View from the Front Lines report. It's figure 72, and figure 72 on page 92. As was mentioned earlier, there are several resources available across the province to further support the work of our community-based programs. In 2011-12, we added to the list of available resources that programs could identify they'd used in the past reporting period for OCHART. These additions included, so historically you would have seen the AIDS Bereavement and Resiliency Project of Ontario, the Ontario Organizational Development Program, the African Caribbean Council on HIV in Ontario, HIV/AIDS in Ontario. This past year, we added the Ontario HIV Treatment Network, or the Evidence-Based Practice Unit, which is a team at the OHTN, which houses OCHART and many of your case management systems. The Gay Men's Health Strategy, the Ontario Aboriginal HIV/AIDS Strategy, and we added ACHO this year. My apologies. These resources are not new and have been available to agencies for many years. What is new that only now we've started to ask you about your use of those services in OCHART. This will help both the provincial agency and the funders gain a better understanding of how these supports are being used across the province. When we look at figure 83 on page 104, we see that about 80% of agencies reported using some type of service from the Ontario HIV Treatment Network, and about 35 to 50% reported using support from the population-based strategies, whether that's the Gay Men's Sexual Health Alliance, the Ontario Aboriginal HIV/AIDS Strategy, or the African Caribbean Council on HIV/AIDS in Ontario. When we look at the data a little more closely, we do see that smaller agencies with less than 5 full-time staff, seem to use these services less than the larger agencies. We wonder why this is, when we would think that smaller agencies could also use those resources and support. Again, we're not sure how to interpret this data. Do smaller agencies have less capacity to access those provincial resources? Are some agencies more or less aware of the supports available to them? Or do the provincial agencies providing support need to revise their services to better meet the needs of smaller organizations? These are questions that we've asked the provincial resource groups to consider during this afternoon's breakout session. So this brings us to the end of our presentation, a formal presentation of the OCHART data. You have the report in front of you. There are lots of figures, there's lots of information in there that we haven't necessarily gone through, but we really do think this gives you a high-level overview and picture of what's happening or what happened last year in the province of Ontario. We know it's a lot of information to take in, and we can encourage you to take some time after the KTE day to continue to go through the view from the front lines yourself or with your staff. We also want to take this time to remind you that if you want additional data or other figures and charts, you just simply have to contact Greg Mitchell at the OHTN and put in a request, and we can provide that. Some of you earlier this morning actually talked about that, having reports run specifically for you on the data set and your use of them.